Hello, my name is Talib Küçükcan. I welcome you to the Digital Debates by TRT World Forum. Today, we are going to discuss vaccine diplomacy and the issues related to vaccine. COVID-19 is still with us, and it is threatening the lives of many people. And of course, on the other hand, many states and organizations are taking measures in order to eradicate this disease. Of course, now we face a lot of challenges as far as vaccine is concerned, because some countries do have access to vaccine, whereas some others do not have the same resources to have access. So we will also discuss such issues as well. I have got three excellent speakers today. Dr. Irshad Ali Sheikh, who is the WHO Turkey Health Security Team Lead. So he will be with us. And also Dr. Baharat Pankayna, Senior Clinical Lecturer at the University of Exeter Medical School based in UK. And we have the other guest from Africa. He is Dr. Ahmed Ogwal Oma. He is the Deputy Director of Africa Centers for Disease Control and Prevention. Gentlemen, thank you very much for joining us at the TRT World Forum Digital Debate. Now, I just would like to start with Dr. Irshad Ali Sheikh. Dr. Irshad, months after the approval of several successful vaccines, we are beginning to see some societies around the world start to open up again. In your opinion, what is the timeline for returning to normal life, if there is anything that we can call normal? Whether we are going to live with COVID for a long time to come, or otherwise, whether we are going to have a normal life in our economy, in schools, in education, in other areas.
So good morning, good afternoon, good evening. First and foremost, thank you for inviting WHO to your show. With dose of humility, one thing we can safely predict about this pandemic is unpredictability. But having said that, I think looking at what has happened over the past 14 months or so, the world is at a stage where it requires a dose of optimism, but realistic optimism. And I would say even cautiously optimistic. So yes, we are at the stage where we can see the light at the end of the tunnel. Vaccines are out. They are highly effective, way more than we would have dreamt about them. We were talking about 50% efficacy would be acceptable 8-9 months ago. We have a couple of vaccines and they're coming into the market. But one thing is clear, that normalcy will come, and as Dr. Hans Klug, our regional director for Europe, famously said the day before, the start of 2022 or early 2022, we may see return to some normalcy and the beginning of the end of the pandemic, if I can say. But the return to normal will be slow, incremental, measured, and monitored. And there may be also back and forth to adjust our speed, scale, and scope of return to normalcy. Other thing as to can we return to normal as we knew it? I think one thing is clear, that the future is not what it used to be. But it's not dreadful. It's not going to be that all indoor activities will be abandoned and we will be wearing masks all the time. Some behaviors may come positively. Teleworking, where it's not needed to be personally together. Telemedicine is a thing that has come really to the fore. And normalcy would look more like, seemingly like where we are with flu in the previous years. We will have different strains. We will have a vaccine. We will require most likely a booster every year. And we will learn to live with it like flu, with a reasonable load of mortality and morbidity, but with some understanding that genomic surveillance will need to be introduced, monitoring will need to be strengthened, and collaboration, north-south, south-south, academic, private sector, philanthropies, regional, global health governance model, all those things will be part of the new normal.
Well, thank you very much. I think this is a very cautious optimism, if I can say so. I think, but also I think we need to take into account that there should be a global I think, fight, not only a regional or a country-based issue. I think that brings me to Dr. Bharat Pankania about the vaccine diplomacy. Let me phrase the question as follows, Doctor. The concepts of vaccine diplomacy and vaccine nationalism have emerged as buzzwords in the discussion over vaccine rollouts. In what ways do you feel these terms have shaped conversations about COVID-19 recovery worldwide?
So these are new words that people were not even aware of, and what the concept meant: vaccine diplomacy and vaccine nationalism. But they are very, very important concepts. And I need to start by mentioning to all of us is an ancient Sanskrit saying. So this is thousands of years old, where the scholars in Sanskrit said, Vasudevai Kutumbam. What that translates to is the whole world is one family. And therefore, it takes us to this issue of the newly developed vaccines that have been successfully made and marketed and found to be working. Then the problem arises of nationalism and diplomacy. Because if we do not treat the whole world as one family, we are causing a problem for ourselves, considering we have been so successful, so clever, and so lucky in developing a vaccine that works. What I am getting to is, whilst the United Kingdom, the United States, the European Union, all affluent nations of the world may be able to have the plants and the know-how to make the vaccine, give it to their people and administer it, if you don't allow the vaccines to also be shared equally, and at the same time, you then have the possibility of uncontrolled runaway infections in other parts of the world. So if you have runaway uncontrolled infections in other parts of the world, you also are allowing the emergence of variants from this one strain of SARS-CoV-2. And when you have different variants emerging, because you never took any measures to suppress the number of cases, to suppress the infections globally, then those variants could, if we are unlucky, they could come and undo the work of the vaccination process in the United States, United Kingdom, European Union, other richer countries. Therefore, it is very important that we look at the world as one family. Of course, no politician is going to start giving away his vaccines without immunizing his nation. Having said that, I noticed Prime Minister Modi from India was doing exactly that, which is something to be applauded. But what I really want is the richer, more affluent nations of the world, with the know-how, with the technical knowledge, to enable and support, for example, the WHO, the United Nations, the World Trade Organizations, all of those important bodies, and under license, under royalties, enable the setting up of extra plants so that we can make more vaccines locally in the regions and give those vaccines worldwide at full pace. We must do this. Even if it takes 3 to 6 months to set up a new plant, it is still worthwhile setting up these plants and giving out, manufacturing the vaccines, and then administering them all over the world simultaneously. This is a very important job that we must do.
Dr. Pankania, I think we all join your wishes in that sense. Otherwise, if the vaccines are produced only in some cities, some centers, and it cannot be distributed to the whole world. I mean, there should be some sort of a local initiatives and distribution all around the world. But this is difficult given the concept that you have just referred to, that is nationalism, vaccine nationalism. And unfortunately, we are living in a world that is very much influenced by such nationalism and isolation. And hopefully that then people can hear us and can also implement what you have said. I mean, I fully agree with you that there must be burden sharing, and all the rich countries, affluent countries should help the rest of the world. That brings me to, yeah, okay, please go ahead.
I just wanted to say one more thing, because as I said to you, the biology of the virus could change and it could undo the job of your vaccines. The second point is this: fellow Africans, Brazilians, Argentinians, Asians are also our fellow brothers and sisters. And if we are going to show that in the time of crisis, we only look after ourselves, then we are also sowing some very bad seeds for the future of world harmony and working in cooperation with each other. Because if you have clearly shown your colors that when the chips are down, you only care for yourself, then later on, when you want to try and do trade deals and work well with Africa and Brazil and Argentina and Asia and other countries, I hope the African leaders will say, where were you when we needed you in our hour of need?
I think that brings us to Ahmed. Ahmed, what is your views about the impact of the pandemic, and to what extent and how far you can see at least reducing the pandemic, economically speaking and health-wise in African countries? Because I think both speakers have alluded to some of the issues that Africa should be also prioritized in terms of addressing this crisis.
No, thanks, Dr. Talib. It's a pleasure to join this digital debate at the World Forum. Africa has suffered in many ways, and let me begin with the perception suffering. At the beginning of this pandemic, there was modeling and predictions of how millions would die, leave alone millions getting infected. Millions would die. And we started off on 14th of February last year, the first case in Egypt, worrying about all the models and the predictions. But as it were, we mounted a very vigorous response very early on in the pandemic, and the numbers have remained relatively lower, in fact, significantly lower than what had been predicted. We've just passed 100,000 deaths, unfortunately, and just not yet reached the 4 million mark in as far as those who have been cumulatively infected is concerned. But the effect on the economy, the effect on our health systems has been very severe. World Bank estimates that in 2020, Africa lost nearly 3% of its economic activities. And this is very significant. In fact, it's the first time in over 20 years, some estimate 30, that there's been a recession on this continent. And this is very significant considering that this is the fastest area of growth in the world. So in as far as the economy is concerned, Africa was hit very hard. This needs to be looked at in the context of the huge loans that many countries in Africa have and needed to service last year, this year, in the next 2 or 3 years, and yet the economies have been shrinking. And this puts a lot of pressure economically on governments in Africa, and the impact is going to be that growth will be very modest in the coming years, because even if it grows, a lot of that growth is going to go into repaying debts and other financial obligations. If you look in the context of response, huge financial outlay is required, not just to be able to secure the necessary infrastructure for looking after those who are infected and protecting the health workers, but also for vaccines now and vaccination. Very huge amounts of money are required, and all these are going to be loans. Very small amounts are going to be in terms of grants or any other bilateral donations. So financially, Africa has been hit significantly, and it will take time to be able to recover. In terms of healthcare, the first casualty is the health worker. We have very few as it is. And exposure to this virus has resulted in many health workers not only contracting the virus, but also dying in the line of duty. And this, by and large, creates an environment of, I don't want to call it fear, but it is as close to fear as you get for health workers. Anyone walking in with any symptoms that look like they have fever, and in the absence of proper PPEs, you already start worrying whether you're going to contract this virus and how it's going to turn out. So that's the first casualty, the health workers. Second are the syndemic diseases, the relatively common, particularly infectious diseases in Africa. Addressing those diseases has reduced significantly over this last 1 year during this pandemic, whether it is malaria, childhood illnesses, HIV, TB. And we are struggling to go back to a level when these treatable, if you want, diseases, or preventable, if you want, diseases, can be able to be addressed properly. So the health systems have been weakened, and this is going to be quite a challenge over the next 3 to 5 years for health systems in Africa to go back to where they were. Finally, I'll say that another part that is not financial and not health related that has been significantly injured, and I think Barata spoke to this very eloquently, is a friendship that is not friendship. We've called it a public health good, the vaccines. Therapies we still don't have, but we don't know which the public health good is actually being referred to. And in this way, as Africa, we are identifying who are truly friends, we are identifying who are truly partners, and we are also identifying who truly represent a place to run to in the event that we have a challenge. The good thing is that it has also reminded us that we need to build our own capacity for manufacturing and amongst many other things. And we are going to do that. This is a promise that Africa will develop its own capacity internally because this pandemic has brought home the clear message that you are literally on your own when something comes and it is big. Thank you.
Right, you are right. I think there is that increasing feeling that the countries and nation states are on their own, but also, as I think all of you have underlined, combating COVID requires global cooperation. It goes beyond borders. It does not recognize any nation, state, etc. I think that this consciousness is quite important. Now, I just would like to,
if I can, just one line there. Dr. Ahmed very eloquently said. So we are requiring partnerships, but not through patronage model. Horizontal partnerships with equal respect and understanding that the old Western-centric models do not work anymore.
Exactly. I think this dependency of one region to another, that should be over. Otherwise, we will not be able to have a global success. Maybe there might be a regional success, but as long as it remains here and there, and we are living in a globalized world, transportation is there, so it is very difficult to contain this, I think, disease. Now, I just would like to raise the idea. I mean, I follow the same stuff. I'm the vaccine. Some countries do have easier and faster access to vaccine, whereas others, as Dr. Ahmed has just pointed out, they don't have the same capacity or the opportunity. What would be the consequences of such, let's say, gap between the countries, and how it will impact the combating pandemic in the short term and in the long term?
Is that the question to me?
Yes.
Okay, great. So I think Dr. Ahmed rightly said that it's the point in our lives where the health and socioeconomic impact from the outbreak is a defining moment of our generation, maybe even the century. But at the same time, as Dr. Tedros from WHO very rightly said, we are at the brink of global moral catastrophic failure. So coming to the question that what will be consequences of this disparity and skewed distribution of vaccines, one is immediate, uniform, and universal, that the pandemic will continue up and down, here and there, Plus, we will see variants because as long as the virus continues to thrive in different corners of the world, with the global connectivity, it's going to come back to haunt the backyard of the countries which may not be willing at this stage to donate or share vaccines. So it is in the best interest of everyone that to have everyone safe, no one should be unsafe anywhere in the world. That is the guiding principle moving forward. Second, if this pandemic continues, it will affect, we have seen very clearly, global travel, trade, tourism, solidarity, culture, science, movement, knowledge transfer. All sectors have been affected because of pandemic. So in a way, it has been a blessing in disguise to tell us, like Dr. Bharati also very rightly said, the Sanskrit one, that this is a global family. And if one member of this family is suffering from a communicable disease, no one will be safe, regardless of whatever armor we wear to protect ourselves. This is one interconnected family. Health systems will continue to be under burden, not just in the countries which are underserved by vaccines, but also it will eventually reach the shores of advanced economies also, because like you said, with travel and tourism, it's only a matter of time when a person with a variant or the virus from areas which are under immunized or non-immunized reaches the shores of. And then if you start putting restrictions, it affects the economy of the advanced economies as well. So it's not that you can create borders anymore also. We saw with Kodak, with car manufacturers, if the car is Japanese, the parts are being manufactured in Mexico, Brazil, Pakistan, India, Egypt. So supply chains were seriously constrained also. So if the virus continues to thrive, supply chains will continue to be affected. And it will affect medicines, pharmaceuticals. It will affect IT, economy. Plus, as Dr. Ahmad also rightly said, healthcare workers. So the not very rightly he said not to be safe, afraid or fear, but the skepticism, because we have families as well. When we are treating a family, we have to take care of our family. So with the contagious disease, those issues will continue to haunt us also, and ERs of any major metropolis will not be safe. You never know who will walk into your emergency room next time with what virus, and what you should be wearing today to protect yourself, because some countries in the world continue to remain unimmunized. So the effects will transcend sectors, economies, populations, and all corners of the world.
Well, I think these are warning in place, and it should be reminded to everyone. Now, Bharat, I will now come back to you again. There are two sides of my question. One is about the research into the vaccine development. To what extent our culture, our approach has changed, because we had to respond to this pandemic very quickly. So this must have changed some of the, I think, working culture in your area, especially as clinicians. Secondly, I think you want to say more about the models of vaccine provision to Africa and Europe, because we are talking about different worlds in terms of economy, in terms of, I think, political structures, etc. What would be your suggestion in that sense, a model for Africa in terms of cost, in terms of access?
So let's talk about the Africa issue first before we go on to the vaccine development. And our colleague, our friend here, Dr. Ahmed Ogwell for Africa CDC, just said that what applies to Africa cannot apply to Europe. Similarly, what applies to Europe cannot apply to Africa. So when the European models, the pandemic preparedness and action plans are drawn up, and the action plans go along the lines of, you are going to go into lockdown, and lockdown means non-essential services, work, activities stop, and you have to stay basically indoors. That cannot apply to Africa, Many people in Africa work on a daily basis. They go to work, they get some money, they eat. If you don't go to work, they don't eat, they don't have food on the table. So this model of we are in international lockdown cannot apply internationally, because you've got to have models that work for individual countries. It's very important. So you need local plans for local people according to local needs. One more thing I also wanted to say is it hurts me a great deal to learn that Uganda, which is a poorer nation compared to European nations and Americans, are paying significantly more for their vaccines to AstraZeneca Oxford Group compared to what Europe and the United States are paying for it. I feel, how is that possible? This is a poorer country, and you're a pharmaceutical company, and you said it was going to be at cost price. So how come the cost price to Uganda is much higher than the cost price to European Union or the UK? We need to address these issues. Now then, coming on to the issue of vaccine development, it's a very good story. So a lot of positivity here. And the positivity here is I'm a doctor, I'm in academic institutes now, and there is a lot of frustration with regards to research studies. So when you want to do a research into therapeutic A or B, there are too many hurdles to go through. It is a very, very slow, long burn before you are successful, 5-10 years of ethical approval, funding, interest, enablement, assistance, coordination, cooperation, working together, etc. It's a long train, and it takes many years. So the lesson we've learned here is not one of we cut corners and we do second-rate research. No, we do first-rate research, always independent, always available for external scrutiny, but we enable it to be done faster and better. So these hurdles that we have of funding, enablement, ethical approval, second phase, recruitment of people, assistance, cooperation, we've learned a lot that if we work together, just like sharing the vaccines and working together, if we work together collaboratively in research programs, we can bring to the market vaccines and therapeutics much faster. So we've learned something very, very important. Work together and we can develop therapeutics much faster.
Well, let's say these are the good sides of this, pandemic. We always, talk about negative aspects, but I think there are some, let's say, good aspects of it until now. Now, Ahmed, you have raised very serious challenges for Africa. And now I think Bharat also said that the cost is different, even for the poorer countries. So how would you respond to this? I mean, whether Africa will be able to manage to produce its own vaccine anytime near, or the distribution of vaccine to different countries will take a long time to come. And if that is the case, of course, as I think Irshad said, the treatment of that illness will take quite a long time, given the trade, tourism, transportation, etc. What's your take on that?
Thank you. I think let me start with the vaccine development piece. This has been unprecedented, very rapid development of vaccines this time. And as Bharat says, it is really because people have worked together. The full genome was made available quite quickly, and using that, then scientists could be able to build a process of coming up with appropriate vaccines. The delivery models of vaccines have also changed, they're improving. So it means that things are being done faster with artificial intelligence, etc. In Africa, there are at least 6 different centers now that are looking into developing locally vaccine for COVID-19. And in fact, Africa is probably one of the leading manufacturers of vaccine for animals, which is not that much different from vaccines for human beings because pathogens are very similar. All that is required is to exercise that extra care of safety and efficacy when it comes to vaccines for humans. So I can't tell you how long it may be able to take to come with a locally and homegrown vaccine for COVID-19 or any of the other pathogens that are really harassing the world now. But what I can tell you is, as Africa CDC, we are supporting local institutions to build their capacity in vaccine development, because we know that another large outbreak will come not too far in the future. Another pandemic will not take another 100 years. It will be much less. We've become very indisciplined. We are walking into caves. We are going into forests, diving down into below the water. We are touching and eating things we shouldn't. So another pandemic will not take very long for it to come. Now, going to the issue of vaccination, as Africa CDC, we've done our mathematics, and if we reached 60%, looking at the current results from the sero surveys that we are doing on the continent, if we reach 60%, we'll be very close, or we'll have hit herd immunity, and this is the target that we have. And our expectation with the plans that we have, if all our resources are aligned well, we should be able to do this within about 12 to 18 months, depending on availability of the vaccines. This is a big barrier to ensuring that we can be able to vaccinate the 800 odd million people on the continent that we would like to vaccinate. Nevertheless, looking at the needs into the future, Africa is 1.3 billion people and growing because half the population is young. And any business person will be able to see, in fact, I think we consume upwards of 3/4 of the world's vaccines that are produced, especially to young people. And it means that the solidarity that we have experienced during COVID-19, our heads of states have met at least 14 times to discuss COVID-19 response. So the solidarity is building, and with time, I am quite confident that it will become apparent that we have a very huge bargaining chip called the market. We will ensure that we get the best deal out of it going into the future, apart from building our own capacity locally. But to be precise, we estimate 60%. We estimate about 18 months to be able to do this, barring availability of vaccines. And we also know that the resources required to be able to do vaccination are great, but they are possible to achieve on the continent. So we are relatively confident that this will be able to happen before the third quarter of 2022. But on the long term, we will be developing our own vaccines in the not too far future, and we will be using our market as the bargaining chip with any partner that would want to come and sell their products here on the continent. And those prices that we are seeing, some of our countries buying at rates that are way, way higher than what the COVAX facility is being given at, than what countries in the West are being given at. We are documenting and we are watching. At an appropriate time, I assure you we will respond.
Ahmed, I just want to make a clarification, for the clarification, until now, what percentage of people in Africa have had access to vaccination? How many people were vaccinated? Any idea? What is the percentage?
It's insignificant at the moment. Completely insignificant. The levels are so low that giving numbers here is not very useful. But also to add that in the second quarter, these numbers will increase because then vaccines will be available at better quantities. Right now, the numbers are very, very small. I would say insignificant.
Okay, thank you.
It's depressing. It's depressing to hear that whilst the United States and the United Kingdom and European Union are racing ahead with vaccinating, there is insignificant. It means very, very few people in Africa are immunized. We need to also ask these questions. Why have you forgotten us?
That's a good question, I think. Now, Irshad, I don't know whether you have got any data on the percentage of vaccination so far. If you got, maybe you can give us a global picture now. And also, I just would like to hear from you the impact of pandemic on the health institutions, because you are into this business for a long time and you got first-hand experience and observation. It has impacted many other institutions, but of course, when we talk about health crisis, I think the first institution that we need to address is the health workers and health institutions. To what extent these institutions were affected, whether they have learned from this process, and for the future, what will be the position that they will adopt?
I think that's a great question. And in terms of global coverage, over 200 million doses have been given across 95 countries thus far. But that in itself gives you a skewed picture that over 100 countries are, and like many in Africa, where not even a single dose has started. So that disparity continues to mar the race in Europe and United States and Americas. On the other side, COVID has had tremendous direct and indirect impact on health systems. Direct, we all know, is global mortality. We are in 2.5 million, 112 million cases across the globe. I mean, just the number is staggering to think about, and then just in a span of 1 year. So mortality, morbidity, but more importantly, and of course the strain on health systems, plus the different versions of resurgence did not even give the same health workforce the time to recuperate and come back and address the next wave. And the reason I say that, when the outbreak started, every country was sort of healthcare worker was running a marathon. And then rates went down, the curve was flattened a little, and then it came back again. In the meantime, we were able to maybe increase some equipment, some supplies, maybe some new institutions, some beds, but you cannot recreate or add healthcare workforce in 1 year. So it's the same healthcare workforce came back to fight, tired, who had run a marathon just months or weeks ago, or even in some cases days ago, to come back and address participate in the next marathon. So in terms of law of diminishing returns, it also affected the workforce, and of course the strain on health systems, and it affected the tertiary care system. So healthcare system is normally built in the world to have very limited spare capacity, so that you do not spend much on underutilized costly equipment. But in this case, when the patients were getting admitted into ICUs and ventilators, you required tertiary care beds to begin with, which was not the subsistence or elastic capacity with many countries. So that is one of the lessons learned. But on indirect side, learning from the example of Ebola, then we had in DRC and Guinea, we knew that in those areas, maternal mortality also increased. Immunization went down, because people were afraid and they stopped going to hospitals. And in many countries in Africa, secondary and tertiary care facilities are the only point of connect of health system between facility and the individual. But this phenomenon has affected globally in countries, advanced economies, US, Northern, Western Europe, and you look at countries like Somalia's, Libya's, Yemen's, and Syria's. Everywhere we have seen decrease in childhood immunization, increase in mental health problems, heart disease, poorly managed non-communicable disease, domestic violence has increased. Children have suffered mental health because they have been disconnected, and in many cases, talking to their peers was the only mental health outlet for many children who did not feel sometimes comfortable at home. So they lost that human touch and peer-to-peer. Suicide in teenagers has increased. Mental health acute conditions have increased. So the pandemic indirectly had created a huge unmet health need that during these episodes of low COVID cases, countries are recuperating to address. And the lesson learned is for preparedness for 21st century, it has to be holistic, partnership based, flexible, and target oriented. But preparedness and readiness is the key. No country in the world can continue to mount a response at the rate, scale, and scope what we have been asking in pandemic, whether it's an advanced economy or a transitional economy or a low-income country. So it has huge economic and inefficiencies in the system as well. So what we as WHO are trying to focus upon are lessons learned for future preparedness. And again, the WHO has recently established its new emergency preparedness center in Istanbul, actually. And we are trying to incorporate the lessons learned for health systems, healthcare workforce, and the initiated by Turkey and adopted by World Health Assembly to have year 2021 as the year of healthcare worker is a token recognition of the great sacrifice frontline healthcare workers, grocery workers, emergency responders have done in this outbreak at their peril, I must say, whereas we have not been able to accommodate them in kind or financially, but they have always stood at the forefront to respond, ready to respond, and we must take care of this in the future emergency preparedness and readiness plans.
Well, thank you for raising this issue, and also I think we need to care for the health workers because they are at the at the forefront of the fight. I just would like to move on to Bharat. I think Irshad mainly referred to countries where maybe we did not have this perfect healthcare systems. What is your assessment of the European health institutions, public health institutions? To what extent they were successful? What were the failures? What were the achievements of health system in Britain, in France, in Italy, in Germany? Of course, there are differences, but when we look from this part of the world, I think they did not meet the expectations. We were expecting a better treatment, better, let's say, dealing with the issues. But we heard that many elderly people lost their lives in Italy, in Spain, in other places. What would be your assessment, general assessment of the health system, and to what extent they can really reform it, given the constraints in many places?
So this is very painful because I spent my life training, practicing, testing out scenarios and reassuring myself, and it turns out reassuring myself falsely, that the affluent nation that I live in, the United Kingdom, has been practicing and testing out systems, and it will manage, because that's what we do. We try and practice and be prepared. And then when the real thing arrived, we were found to be completely unprepared. And that was an absolute shock to my system. The shock being accentuated because in 2016, so it's not a long time ago, the United Kingdom had a very large, expensive exercise testing out a pandemic and what you would do, and the PPE requirements, hospital requirements, respirator requirements, healthcare worker requirements, etc. And we didn't implement the findings of exercise Cygnus in the United Kingdom. And the report was just shelved, and the focus in the United Kingdom has been on Brexit. And whilst the senior politicians have been focusing on Brexit, they took their eye off the ball of pandemics, medical emergencies, and other similar preparedness plans. So we made a number of errors, and the errors go from the beginning all the way to today. So, for example, in the United Kingdom, we didn't do test and trace and isolate the fundamentals of infection control properly and at large scale. We, in fact, stopped doing test and trace very earlier on in the pandemic. Belatedly, we set up, unfortunately, privately. And why I say privately and unfortunate in the same words is it just didn't work. It didn't work because when you set something up afresh, they're not integrated with the network, and you don't have people who've done these jobs before leading on running a new operation. So our test and trace centralized operation has never been successful. Furthermore, over the last more than 10 years, the United Kingdom has been cutting hospital bed capacity under both governments, Labour and Conservative and coalition. So as a result of reducing bed capacity and hospital resilience and reserves, when you suddenly are faced with ICUs, ITUs, hospital beds full of patients, your outcomes are poor. Because when ITUs, ICUs are more than 70% full of capacity, your outcome for those individual patients drops. And that is what we've experienced in the UK. And one more thing, finally, is we made grave errors. The errors being, for example, to increase hospital capacity in the middle of a crisis. The decision was made to send elderly people back to discharge them back to their nursing homes where they had come from. And in sending these people back to their nursing homes to create emergency capacity in the hospitals, many of those people were infected, and they were infectious. And they took their infections to the nursing homes, where once an infection has arrived in a place like a nursing home, it spreads, because a nursing home is not a hospital ward. Infection control measures are very different. The people looking after people in nursing homes are on not big pay, and they don't have PPEs, and they don't have all those things that a hospital has. And unfortunately, we had a staggering loss of lives in nursing homes as a result. It's a big error. And then finally, one more thing. If you intervene early in a person's illness, when you see the first signs of deterioration, and act fast with supportive therapies, the outcomes are better. So what we should have done really is, when we diagnose the cases, even if it was on clinical grounds, we assigned people who could check on these people. So we should have done things like pulse oximeter. And if the pulse oximeter readings were going down, if the clinical signs were indicating that their shortness of breath and tiredness and lethargy and confusion was increasing, we intervene early, take them to hospital, give them supportive oxygen, and save their lives. So unfortunately, considering we know all these things, we didn't do it. And that is very shameful. It is very shameful to accept and admit that we know the science, we know what to do, but we didn't do what we should have done.
Well, I think there are lots of lessons to be learned.
Just one comment. In this case, hindsight is really 2020, and it was year 2020 as well. But one lesson overarching for this is, failing to prepare is preparing to fail. And that is the thing we need to carry forward, consolidating the lessons, but keeping the point that lessons are tailored and remedies are also tailored. As we discussed, Africa's remedies will not apply. Nursing home issue is not an issue in Africa. Same way we saw in Turkey as well. So again, there will be tailored, compartmentalized approaches, but need to be prepared, tested, and readiness. I think the word for future, more than preparedness, it's readiness for these pandemics.
Okay, Ahmed, now I just want to ask you two questions. One question is, it's some kind of assumption. Dr. Bara said that we have to address and we have to ask Western and the European leaders, why did you forget us? This is the question that we need to ask. My question to you, do you expect any satisfactory answer, a reply, if there is such a question? I mean, whether Europeans or Westerners will really give you an answer. This is one part of the question. Second part of the question is, yes, we have been talking about the responsibility of the developed world, but also, the Africa has its own, I think, responsibilities. African leaders, African nation states. What should be the priority of the African leaders and African countries in dealing with this pandemic issue?
Oh, thanks, Dr. Talib. I think that the first question, I'm probably the most inappropriate person to answer. But I will tell you that what we are doing and will continue to do is we'll continue to engage on the basis of equal partnerships, and we will continue to ask these questions. We are getting varied answers, and none have been satisfactory so far. But we will continue to ask those questions and engage on an equal partnership footing. On the second question, which now I think are more appropriate to answer on our priorities, due to time, I will give you three. The first is, and this is based on lessons learned from the outbreaks, the multi-country outbreaks we've been responding to on the continent, and this pandemic currently that we are undergoing. The first priority is coordination across the continent. This is really, in my books, the number one priority. And when the countries are coordinated, when our experts and responders are coordinated, then we are able to get synergy in our response. We are able to get synergy in our planning and resource allocation. We are able to share resources. A good example is laboratory capacity. When the pandemic started, we had zero capacity on the continent. 1 month into the pandemic, we had 2 labs that could be able to do laboratory diagnosis. 2 months after the pandemic hit, we had 6 labs. And these 6 labs did a lot of work for the first 3 or so months as we built the capacity across the continent. Within 6 months, all countries had the capacity to be able to do laboratory diagnosis with zero help. And I repeat, zero help from outside of Africa. It was the African experts who trained their colleagues within the continent, and we could be able to do diagnosis faster and therefore get a firm grip on this pandemic. So it is coordination across the continent. Our heads of states have shown us what needs to be done. We have set up task force for COVID-19, and we are replicating that now that we have a threat with Ebola in West Africa again. We know that when we coordinate, we work better, there are synergy. So that is one, coordination across the continent. And Africa CDC is a good exemplification of that coordination. That is our rule. That is why we were set up. Second is each and every country on the continent must have its own national public health institute or national CDC, whichever nomenclature they want to use. And these national institutions that are technical, that are autonomous, that are capacitated, that are provided with the correct resources, will be the early warning system for the continent. They will pick out outbreaks quickly and control them before they can be able to spread. And in this way, you find that what we are doing at the continental level now will be done at country level for each and every country. That will be my second priority. The third priority is what many people call political advocacy at the highest level. That one of the things that really breaks the back of pandemic preparedness and response in Africa is that it is very ill-funded. It is provided with very meager resources. So you find that you cannot be able to hire the correct experts, you cannot be able to do good planning, you cannot be able to have the correct facilities and tools to be able to do what needs to be done. While in pandemic preparedness and response, we know what needs to be done. We have the tools for doing what needs to be done. But you find that at the time that it is really required, there's no budget. And this is, for me, really a very big failure in systems across the world. And in Africa, this really will be the third priority, to properly capacitate these institutions, whether they are national, whether they are sub-regional, or whether they're continental, to properly provide them with expertise that will be able to do long-term planning and making the continent ready for early detection and rapid response to any public health outbreak that may be there. While doing all that, we must do it in the context of it is time for a new public health order. This old system where a group somewhere, I don't want to mention cities and countries, but where a group somewhere will then be able to say this is what needs to be done, that's gone. Within a country, you will find different parts of the country have different contexts, and the response to an outbreak. Let me take Nigeria as an example. If I go to northern Nigeria, it will be totally different from southern Nigeria, leave alone West Africa and Southern Africa. So this old public health order of everything comes from one source is gone. It is buried. And I think COVID just put the correct nails onto that sort of school of thought. And we as Africa CDC, Africa Union, we are walking into a new public health order, which will be determined by utilizing international experience, but action has to be local. And everything has to be adapted to the local context. That is the only way you can be able to be ahead of the curve of any public health challenge going into the future. It is time for a new public health order. Thanks.
Thank you very much, Ahmed. Now we are coming towards the end of our debate. My last question is to Dr. Irshad. Turkey doesn't have a vaccine. I think if it had, it would have shared it with others. You would remember that Turkey has sent some, medical equipment to almost 100 countries. How would you evaluate that in terms of, let's say, pandemic diplomacy, as coined by Dr. Barat?
Thank you very much for bringing that right message at the end of the show of global solidarity. Turkey was one of the countries that lived the example of global solidarity. When we had at the start shortage, relatively speaking, shortage of PPE, ventilators, Turkey sent equipment to 135 plus countries and 5 international organizations. Though nationalism was also a concern of course, is for every government, but they realized right up front that if we help today others, tomorrow it will be investment. But more than is the message of global solidarity and humanity, 4.5 million refugees have been in Turkey for many years. And if you remember, soon after the pandemic, there was a decree issued that all pandemic-related care for anyone inside Turkey will be emergency care and will be afforded and subsidized by the government. That had a huge impact on making sure we are testing, tracing, and treatment capacities without fear of discrimination. So I'll bring last point, which is our mantra in WHO, especially European Programme of Work, leaving no one behind. And Turkey, being one member state in the European region, showed WHO what can be done, though you are under pressure, though there is skepticism, though there is fear, unpredictability, but we can only thrive as one family. Ending at the lesson that we started from Sanskrit, we are one global family.
Well, thank you very much. I think 2 other speakers will have a few more minutes as they write. Dr. Barat, what would be your, let's say, last comments or calls or recommendations or anything that you would like to share with us in 1 minute, please?
Okay. This is a global world. We need to act globally. And it is really a case of we cooperate, we are better. So we need to work not only on vaccine development, but on therapeutics, technology transfer, and all the other things. Nationalism only hurts our fellow brothers and sisters in other parts of the world. We need to be more cooperative.
Okay, Dr. Ahmed, the last words are yours.
The very final thing I would say is that we have learned that each and every country, each and every grouping need to have their own local production of materials, of equipment, of therapies that they will need in ensuring that they protect their citizens. If that works out the way that we would like it to work out in Africa, then the whole area of vaccine or therapy nationalism will just die a natural death. So each and every country, each and every groupings of country, each and every region must develop their own local production capacities so that they are not left hanging when the time comes when vaccines, therapies, and other commodities are required for public health response.
Gentlemen, thank you very much for joining to TRT World Forum Digital Debate. We have discussed about all the, I think, important issues related to pandemic and vaccine, and we hope to see you at a different venue at a different time. Thank you very much for your participation. Thank you, and goodbye to all our audience today.
Thank you.
Thank you.
Thank you.